cancer. It has to be a collaborative process between the doctor and the patient. And I've even seen that taken to some ridiculous levels where some doctors will say, it's your decision, just tell me what you want to do. The doctors that I dealt with were much more collaborative and said, look, here are your options. Here's what I would recommend, but you should go out and meet with people that you think can kind of illuminate the matter for you. So, for example, I met both with a radiation oncologist and a surgeon, and then, of course, a number of urologists and physicians and PAs along the way. And my thought process eventually took me to surgery. But, had I been 10 years older, I might have gone with radiation. It just depends on your particular situation. So for me, it's all about ownership of the healthcare process and decision-making process.
Yeah, and beyond ownership, you did something that I think a lot of us would actually find very difficult. You fired your first physician, effectively.
I did.
He wasn't supporting you in a way that, and we're not talking about a diagnosis or work. But the two of you just were not connecting on an emotional level where you felt comfortable with him. Can you talk about that a little bit? We're not going to name him because he wasn't named in the book, but could you talk a little bit about that process of, okay, I've got a doctor that I'm asking him a question and he's he's sarcastic or belittling me in a way that I just don't feel like he has my best interests at heart.
Yeah, this doctor was honestly, I think, a good guy and an excellent physician. But like anything in life, certainly in healthcare, which is such a human interaction, I just believe that you need more than mere expertise. You need somebody who respects you as a human being, who understands that your approach to making decisions about your healthcare might be different from the other patient, who doesn't, I don't care for sarcasm. If somebody's dealing with cancer, the last thing they need is sarcasm. So this particular doctor and I simply weren't clicking for, as I mentioned in the book, I had been advised early on to get an MRI before I had a biopsy. And I pushed really hard with this doctor to do that because the idea is that an MRI gives you a visual picture of the entire prostate before you go in there and start poking needles. Because if you don't have that visual picture, what you might end up getting is an incomplete diagnostic perspective, which is what in fact happened with me. We only got two cores when in fact I had quite a large tumor. So I pressed this particular doctor for an MRI, and he responded largely by saying he didn't think it was necessary, it wasn't the best practice, and made me feel a little bit like a hypochondriac for asking. Well, later, when I was still considering using him as my surgeon, I subsequently went to Sloan Kettering. And the first thing they asked me was, did you do an MRI before your biopsy? And I said, no, my doctor advised against it. They said, well, here we wouldn't consider doing a biopsy without an MRI. So that entire view that I had taken was very much validated. And it was also just the manner in which he opposed me on that decision. It just felt like he was asserting his medical, I don't want to say supremacy, but superiority. And you're a patient, I'm a doctor, you need to listen to me on this. And not acknowledging the fact that I'd done my homework.
Yeah. Well, and realities, the generation before us and before that, when the white coat walked in and said, do this, we just did it. But now with the advancements in medicine and what's going on in the world, standard of care changes all the time. And for the doctor to be up to speed and say, no, there is a standard of care. And if there's, reason to believe that doing an extra step is going to give you a better outcome. I was just surprised that when you said you were willing to pay out of pocket for this, because you were told you would probably have to do that he just said no. Whereas it would just been a data point. I'm a big fan of the more data points you have, the clearer things can be, as long as you just don't get overrun with it. But I think it would have been a point that you obviously now, hindsight, definitely should have had.
Absolutely, and the fact that it was validated the way it was, and validated with really good information, in the sense that the folks at Sloan Kettering explained that biopsy should, first of all, it's not something you want to go back in and do, but also it causes bleeding because you're poking all these holes in the prostate. It causes bleeding, which obscures any subsequent MRI image for several weeks after that. So it actually impedes the ability to get a good perspective. So there's really a very practical reason to do an MRI beforehand. Now, you mentioned standards of care. The problem with dealing with prostate cancer is that standards of care they're changing, they're shifting back and forth as new data comes in and as doctors debate what to do. Another example of that would be the level of sedative or anesthesia they give you for a biopsy. A biopsy is pretty painful. Either I'm a wimp or biopsies are pretty painful.
No, I don't really 12 holes. I think 12 holes in a human body.
Yeah. Particularly in that area, it doesn't feel good. And the standard of care is to give you at most a Valium to calm you down and a local anesthetic. Well, when I asked the doctor after the biopsy was over, I said, "Wow, that really hurt. Has there been any discussion of putting guys under general anesthesia?" He said, "Yeah." He said, "Actually, to his credit, he said I've been proposing that for a while, but it hasn't been adopted as a standard of care." And so that's one of those examples where it's an evolving thing. And I think to a certain degree, medicine is always kind of catch up with what it's learning from patients. And frankly, part of my objective in writing the book was to educate doctors as much as patients about what the process is like, so that when they realize, oh, gee, these biopsies really hurt, or, oh, gee, it makes it more complicated for a patient if we don't let them do an MRI beforehand, maybe that's something we can revisit, whether it's on an individual level or on the standard of care level.
Now, you mentioned earlier three different approaches to treatment. You were past one of those by already being a 6. But do you mind going through those 3, and then in particular the 2, the surgery and the radiation, spending a little bit of time talking about the pros and cons of that?
Sure, absolutely. So the 2 most common forms of treatment for prostate cancer are either a prostatectomy, which is surgical removal of the prostate, and by the way, it's always the entire prostate. There's no such thing as taking out part of a prostate, which was illuminating for me at the time. You either take it all out or you leave it in. There is, and the other option is radiation therapy, which irradiates the prostate gland and potentially some of the areas around the prostate with radiation to destroy the cancer cells. They've also developed for men who are very early with a very localized cancer, a small low-grade cancer, what they call focal therapies, which they use all kinds of exotic things like cryoablation, where they go in and they actually freeze the cancer cell with a needle. Those focal therapies, as the name suggests, are very focused. They're for a very well-located, small, early cancer. By the time they found my cancer, I was a stage 3. The malignancy had moved out beyond what they call the prostatic capsule, or the envelope that is basically the membrane that surrounds the prostate. So I was, by virtue of that, and it was, I think, a 2-centimeter tumor, I was not a candidate for focal therapy. So for me, it came down to either radiation or surgery. Now, I should also add that for many men, particularly men who are potentially in their 70s and who have a slow-growing, low-grade cancer, they have what's called watchful waiting, which is simply to do nothing and to go in maybe every 6 months or so, get your PSA checked. And if it's really not growing quickly, there's a great likelihood that men like that will die from some other natural causes before the cancer ever presents any real problem. And that is very much something that's being recommended for men who are older. I was not a candidate for that because I had a very high PSA, and it was changing. In fact, it changed from about 15 to about almost 20 in the space of 6 weeks. So they immediately ruled out watchful waiting and the fact that I was in my 50s. So the decision for me came down to surgery or radiation. And surgery, I think, I'd have to check this, but I think surgery is more common. There's been a lot of pushback among some doctors against surgery because they think it's too often proposed for people who could have avoided it, and I think that probably was the case. It's less so now. But there are various types of the surgery that's performed. The most common now, I think, is a laparoscopic radical prostatectomy, which is the doctor uses a laparoscope that goes in basically through 5 small incisions in your abdomen they use laparoscopes on for example, to repair damaged knees. It's a way of having a smaller incision and cutting less tissue to make repairs. So you get 5 small incisions into your abdomen. They go in with these kind of like robot arms, and they, with the doctor looking through a video monitor, they remove the prostate that way and fix things up and send you on your way. Radiation, on the other hand, is a process of going in, I think, typically for about 6 weeks, 5 times a day, and lying under the beam. And the pros and cons are, with radiation, they don't remove the prostate. So some of the side effects of not having a prostate are entirely avoided. So there typically is less, I think with radiation, there are less issues with continence, less issues with post-treatment potency, and a man still has his prostate. So physiologically, he can still produce semen, which a man cannot without his prostate. So for a lot of men for whom radiation is an option, it's a good choice because it has less of an impact on their sex lives. So as an example, and my own brother-in-law went that route and was very pleased with it. The trick is, and this is what helped me form my decision with surgery, by the time we had my MRI results and they kind of accurately staged my cancer, they knew that I was a stage 3, they knew that it was aggressive, and they knew that it had moved outside of the prostatic capsule. It was likely, in fact, I was told I had about a 50-50 chance. My radiation oncologist explained I had a 50-50 chance of needing radiation after surgery as well. So if you have radiation as your first line of defense, the tissue is so substantially changed by the radiation that it really can't handle surgery afterwards. Now, Sloan Kettering has developed what they call salvage radical prostatectomy, where they will go in, if necessary, and remove a prostate that's already gone through radiation. But it's very tricky, and recovery is tough, and there are a lot of side effects to it. So generally speaking, if you think you're going to need radiation later on as a follow-up because maybe the surgery couldn't get all the cancer, guys will go prostatectomy first, radiation second. It's worth noting, too, that the cure rates are about the same for radiation and surgery. So making the final decision very much comes down to how bad is the cancer, how fast is it moving, how old are you, what's your life expectancy, all these variables that are unique from man to man. And it was that process for me that was really kind of essential, kind of core to my experience of cancer, which was realizing that just because my brother-in-law got radiation and it worked for him, and just because my best friend got surgery and it worked for him, everybody's different, and you cannot just make a decision based on kind of generalized views of these treatments. You really need to dig in deeply and understand your own cancer.
Yeah, and I think that was kind of the core, because you had done some research and found surgery's gone really bad, and like you said, the radiation could have done something, and then it would have been much more difficult if there was a reoccurrence. So it is something to strongly consider as far as what you feel good about, and what the facts in your particular case are saying. It's one of the parts of treatment.
Let me help our doctor. I called from the phone talking about this cancer, prostate cancer. My name is Reggie, the CEO and the chairman of Reggie Prostate Cancer Foundation. This foundation was established in 2018 when I was diagnosed by the prostate cancer diagnosed with prostate cancer. Due to the process I went through, the pains, a lot of things I went through, because if you check out what the doctor said about the prostate cancer, he said everybody have different opinion and different lifestyles and different body reaction on different treatment. In the prostate cancer, we have 5 treatments, which stage 1, stage 2, stage 3, stage 4. If you are stage 1, you can go to radiology. No, first of all, that time is not what you call germinating enough. What we normally do, they have to do what is watching weight. That time it was a little. But the next one, when it was stage 2, the next one they have to do is surgery. Some people use surgery. Some people do radiation. Some people do chemotherapy. Some people do homotherapy. All this is a treatment for prostate cancer. It helps a lot. But the only thing is chemotherapy and this homotherapy is 50-50. It's 50-50 because it must, that's what I'm talking about. It must, when he was at the stage of 3 and 4, it's very 50-50, very dangerous. That's what I'm talking. And we have to mind our diet. I'm not going to talk too much about this food. The only thing, the moment you become 40, because now, before they say it's only old age, it's not old age. From 40, you can get it from 40. You can get it 45. But the moment, you always, when you're getting like 40 years, try to check your PS every 6 months, whether it's high or low. All these things very important. And we have to mind what we are eating. Our diet. What are you going to drink and not what are you going to eat? It's not everything. All this junky food is not good for our body. We have to change our lifestyle. It's going to help us. With all these our lifestyles, we have to defeat this prostate cancer. Let's change young youth, because if you check out nowadays now, people, young youth are dying like chicken, and we don't want to let them to repeat again. That's what I'm saying. And what the doctor say, if you check what the doctor say here again, if you say what the doctor said.
I guess I didn't really think a whole lot about, I thought, okay, well, you have the surgery, they remove it, you heal up from the sutures and you're on your way. That's not the case with prostate cancer. There's a lot of post-treatment that needs to occur. And without going into all the gory details, I can kind of talk about, because you need to buy this book, if nothing else, to read that story. But can you go through some of the details, some of the things that you have to do just to get yourself back to normal?
Yeah, the main, and of course my experience is specific to the surgery. I can't speak to radiation, which does have its own side effects. What I didn't mention is that radiation can have side effects affecting potency and incontinence, but they tend to be deferred by 6 months to a year, whereas with surgery, those side effects, of course, are immediate coming out of surgery. But the typical things that a man needs to worry about coming out of surgery, of course, is potency, which requires obviously intact nerves and an intact blood flow to that part of the body. And sometimes the two nerve bundles that make an erection possible are affected by the cancer, and one or both have to be removed. Now, you only need one, but if even one is removed, that's going to require some post-surgery work, which we can talk about. But under any circumstances, the trauma that's done to the body during the surgery, particularly the nerves in a man's groin, send those nerves into what they call hibernation mode, which can last for 1 to 2 years, where the nerves simply don't work properly. They're healing, and they just kind of like a bear going into a cave. They just stop physiologically functioning during.
Now, talking about the doctor talking about it affects a lot of things. That's why Elia Libera, what we have to do, we don't want to say you have to go to our website, www.reggie.foundation.org. There you find out our own what you're supposed to eat and what you're not going to eat. or mostly you have to do the exercise. Exercise is good. It's cured. It's decrease the risk of prostate cancer. We gotta do it. We gotta do it. And again, mind what you're going to eat. All these things save lives. It helps us a lot. And when you go there, please have your donation. Go to your donation with www.reggiefoundation.org. Make your donation because we need to save life. Because we need to give treatment some young people who cannot afford to pay their bills. We gotta pay them. We gotta help them. That's why our mission, and to educate people with your wage, with your money, we can save life. I'm about to sleep. I'm nice tonight because I'm talking to every time. I'm still to educate people in the YouTube place. You can go to my YouTube, subscribe. You go to WhatsApp. Any place you go, you see me. You go to Facebook, Instagram, Twitter. I'm there because every day. That's why I say I'm going to educate. That's part of my job. I say good night for everybody. God bless you. Please go to my website, make a donation with your figure. Thank you. Go and make a donation with your any